Good afternoon, my name is Brooke Gallman. I'm a PGY1 pharmacy resident at Piedmont Athens Regional, and today I'll be presenting my research entitled The Assessment of the Number and Cost of Hospital Visits in COPD and Asthma Patients Before and After Patient Assistance Program Enrollment. All researchers involved in this study have nothing to disclose. One of the primary research settings for this project was Piedmont Athens Regional, a 360-bed nonprofit community health system that serves 17 counties in northeast Georgia. The second site was an extension of Piedmont Athens Regional, the Community Care Clinic, and it provides primary care to the underserved population in Athens, Georgia. And this clinic also frequently utilizes patient assistance programs for qualifying patients. It is no secret that medication costs have increased over the past few years, an increase so significant that many may be forced to go without necessary medication due to high copays. This is especially true for those that are uninsured, but specifically in the case of COPD and asthma patients, they may need an inhaler that retails for $200 to $300 a month to control their condition. And if they have to go without, they run the risk of having an exacerbation, which leads to more acute healthcare utilizations, so more ED visits and more hospitalizations. And if they are unable to pay the hospital bill, the health system is forced to absorb the unpaid costs. So both parties are stuck in this never-ending cycle. To help assist with this burden and break the cycle, certain drug manufacturers have created patient assistance programs, or PAPs, and these programs are available to qualifying patients to obtain high-cost medications for chronic disease states, and having consistent access to necessary medication can increase adherence, and this will obviously lower monthly costs for these patients and can keep them out of the hospital, which will reduce overall health system costs. However, you may not have heard of these programs because they are severely underutilized for several possible reasons. And to list a few, some providers may not be able to dedicate resources to finding these programs for patients, and there is a severe lack of literature to assess the efficacy of these programs. This leads me to the purpose of my project, to evaluate the impact of PAPS enrollment on healthcare utilization in patients with asthma or COPD. The primary objective of the study was to compare the number of ED visits and hospitalizations related to asthma or COPD before and after PAPS enrollment. The secondary objective was to characterize the cost of ED visits and hospitalizations before and after PAPS enrollment. This was a single-center, IRB-exempt, retrospective observational cohort study. The data collection time period included patients who were initially enrolled in PAPS from January 2018 to March 2019. Chart reviews of each patient included 6 months before and after PAPS enrollment, and therefore the total data collection time period spanned from July 2017 to September 2019. Patients were included if they were a patient of Piedmont Athens Regional Community Care Clinic, greater than or equal to 18 years of age, and obtained medication through PAPS to manage asthma or COPD from January 2018 to March 2019, and they are excluded if they were pregnant or incarcerated. Data collection was initiated by identifying qualifying patients through clinic records. Once patients were identified, EMRs were used to determine the number of hospital encounters related to asthma or COPD within the Piedmont Health System. Dates of hospital encounters were documented as well as the total number of encounters. And with this information, I was able to perform a cost analysis through Piedmont Health System financial records. 269 patients were identified and 213 patients were excluded because they either received medications for other indications or did not receive the medication within the specified time period. So 56 patients were included, and of these patients, 28 patients had at least one ED visit or hospitalization. These are the baseline characteristics of my population. I have included the total population as well as a subgroup of those with at least one hospital encounter. I would like to point out that the median age is similar in both groups. Also, there is a similar proportion of males to females, and COPD is the primary diagnosis in both groups. This is a list of the initial medications received through PAPS by these patients. The most common inhalers prescribed were the 2 albuterol inhalers, which can retail for about $50 an inhaler, and this was followed by the fluticasone vilanterol inhaler, which can retail for about $350 an inhaler. So all of these patients are saving a substantial amount of money each month. So looking at the primary objective for hospital encounters, this graph depicts the cumulative number of hospital encounters between all patients before and after PAPS. Before PAPS enrollment, the total ED visits was 54 between these patients, and this decreased to 7 after PAPS enrollment. Likewise, the total number of hospitalizations between these patients decreased from 13 before enrollment to 0 after enrollment. So these specific results were reported in medians because the data was non-parametric. So of the patients who had at least one hospital encounter, the median ED visits decreased from 1 with an interquartile range of 1 to 2 to 0, and the total amount of hospitalizations were small, but of those that did have a hospitalization, this number decreased significantly as well. This graph depicts the cumulative cost difference before and after PAPS. The first two columns show the difference in the cumulative amount billed to these patients by the healthcare system. This decreased from about $554,000 before PAPS to $11,700 after enrollment. The second two columns shows the difference in general acquisition cost to the hospital. So what that means is what it costs this specific hospital to treat a general ED visit, which is about $702, and a general hospitalization, which is about $4,830. And this would include the mean direct cost to the hospital, but does not include provider fees. So for these patients, the cumulative acquisition cost decreased from about $101,000 to about $5,000. And of the patients who had at least one hospital visit, the median amount billed to these patients decreased from $4,683 to 0, and the median hospital acquisition cost decreased from about $351 to 0, and both of these results were statistically significant. There were a few limitations to this study. It was a retrospective chart review, so there is potential for inadequate documentation from past charts. Also, in EMR reviews only included Piedmont Health encounters, and if a patient went to another healthcare system, I did not have this documented. And although it can be inferred that patients were compliant based on these results, there was no way to properly document patient compliance once the patient was enrolled in PAPS during this time period. And finally, some patients may not have had access to primary care before a hospital encounter and were then referred to the community care clinic. In these cases, PAPS may not have been the only factor associated in a decrease in acute healthcare utilization. Overall, I found that PAPS enrollment led to a significant decrease in utilization of healthcare services, and this in turn led to cost savings for patients and the healthcare system. And for my self-assessment question, do patient assistance programs have the potential to lower acute healthcare utilization? Yes, they do. Thank you so much for watching.